is Dr. Karen Adams. I've been working in the field of pheochromocytoma paraganglioma for the last 15 years. There's a couple of ways they can find out, either through familial, that they found out through their family. They are carrying the gene mutation for pheochromocytoma paraganglioma, and they would be tested, genetically tested that way. Or they would end up, unfortunately, getting the disease and then finding out that they have a pheochromocytoma paraganglioma, going that route. So two ways: finding out you have the disease, and the second way would be to find out that you're carrying the gene mutation through the family. Oh, a loaded question. This is considered one of the most misdiagnosed cancers. So signs and symptoms are high blood pressure, anxiety, panic attacks, heat intolerance, palpitations. So as you can see, that these signs and symptoms are very common. And often patients go to their physicians with these signs and symptoms, and they're just disregarded as having panic attacks or just being sweaty or, things like that. And they're just disregarded. They're put on maybe a blood pressure medication, maybe an anxiolytic medication, sent on their way. And unfortunately, these tumors are growing. And when they end up in the emergency room in a hypertensive crisis, then the patient finds out they have metastatic disease. And by then the disease has spread. The most accurate way is biochemistry, which is both urine and plasma or blood. Although we do have a small cohort, there are a small cohort of patients who do test negative for the biochemistry. So really the most accurate way, of testing for this is a simple CT scan, neck, chest, abdomen, pelvis with contrast. A scan without contrast is useless, so you have to use contrast. And also doing the either 24-hour urine and or plasma metanephrines and catecholamines, which is the hormones that these tumors secrete or produce. We call them screening patients. So if a patient has the mutation but does not have the disease, after the baseline, which is the baseline is at when they first find out that they have the mutation, usually every year they should at least have the biochemistry drawn, plasma and urine metanephrines and catecholamines, and every other year do a scan. And the every other year after the baseline CT could be MRI of the neck, chest, abdomen, pelvis. And then maybe every third year or fourth year, then do the CT or a PET scan again. Depends on where the tumors are located and how big the tumors are. You always want to debulk or get rid of the tumor tissue. So yes, you want to do surgery first if you can. Surgery, if there's too much tumor tissue, then you want to do either chemotherapy or using MIBG or dotatate as a treatment to shrink the tumors and then remove them via surgery. There's a strong psych component with this disease, unfortunately. Many of my patients will say to me they feel like they've been revved up on 1,000 cups of coffee. Their hair just stands on end at times, and it's very episodic. And you have all of this adrenaline in your system, and it precipitates panic attacks. And what I've seen over the years is, especially with our younger patients, when you remove these tumors, if you're not careful, patients can become very, very depressed. And I've actually had, not my patients, but I've heard of patients committing suicide. Because you take away all that adrenaline, people get really depressed and they'll commit suicide because they've been living with the adrenaline high for so long. This is something that's been gone unspoken, and I think it's something that needs to be addressed. Oh, it impacts families on several levels. I mean, you live with this monkey on your back, having to worry if and when you're going to end up having the disease. Will you survive the disease? Are there going to be treatment options? Having children is exceptionally difficult for families because you're wondering if you have a child, will they have the mutation, and then will they have the disease, and will they survive? And so it's very, very stressful and very difficult on families. And pheo-rage is when these patients that have disease or not known of the disease, they just have these outbursts of horrible anger and rage, but it's very episodic. And so they'll, feel okay, and then they'll have this moment of, I've had patients describe driven really fast, aggressive driving, or put their fists through a wall, or just feel like wanting to just, do something horrible or kill somebody, and then the feeling goes away. One of the things that I've thought about is how many people, you hear of these, people getting very angry, but how many people are in penitentiaries that could have these tumors because you hear them that, they've said something like, I just had this moment where I just wanted to kill this person and I don't know what came over me. Those are the red flags that people need to pay attention to, and they're not. And that is called pheo-rage. We have patients who they're dealing with all of this adrenaline, so they turn to drugs and alcohol. And they become addicted to drugs and alcohol to down it because they don't know what's going on. And then they go to the doctor and they find out they have disease. You remove the tumor, but you're still addicted to the drugs and alcohol because this is not uncommon, so, and especially children with this disease really need to be followed closely with psych because they're the ones who really have a hard time dealing with when you remove, not only going through all of the scans and having all of this, but when you remove the tumors, they're the ones that get depressed and have problems. So this is something that that the psych and the medical community is not really paying attention to. We're finding out now more and more that there are several syndromes to this disease. Not only is it the metastatic pheochromocytoma paraganglioma, we're finding now that it is related to some breast cancers and of course some kidney cancers and pancreatic cancer. So it's very important to be monitored closely, and this is again not a benign tumor. Oh, absolutely. And that's one thing that I have learned over the years with my patients and bringing the patients together, because going back to the psych component, nobody wants to listen to them that they're feeling this way, that they're having these, bouts of sitting in a classroom and all of a sudden just getting sweaty or feeling the feeling of doom coming over them, so they don't want to talk to people about it. And then you put some patients in a room together and they all, at some point, all have the same signs and symptoms. They all do. I've been listening to this for years, and it's, for me, back in 2007, when I started the Pheo-Para Alliance, that was one thing that was very gratifying to me, was to bring these patients into a room and say, you guys need to talk and support each other. And I found that to be interesting, and some patients want to deal with it and some patients don't. Some patients want to talk about their signs and symptoms with other patients, and some just don't want to deal with it at all and just kind of swallow it and go on, and those are the ones that I'm worried about. Yes, I think things are getting better. We're not there yet, and it's like a marathon runner that we're just, that's running, and we're running behind, running behind them, well, I think we're one step ahead of them, of the marathon runner, and we're really starting to put some treatment options together. But I would hope in the next 5 years that we would have some better treatment options. I do. I think that now with the stem cell therapies that are going on, and also, doing a lot with gene therapies. Yes, I do. I'm very optimistic that if things continue to progress as they are with the immunotherapies and everything, yes, I do. I think that the future is bright for this disease. When you have the mutation, it's between 75 to 85% that you'll get the disease in your lifetime, okay? And I don't think that information is out there, because patients with the mutation they feel fine and that's it, and they're not getting screened for the disease. I strongly encourage people to not only follow up after baseline, because feeling fine, these tumors are very slow growing in your body. So your body accommodates to them, and that's why this is why the issue with people saying, I feel fine, they go to the doctor, they find out that they have a tumor in them, and they don't realize it because these are very slow growing and they accommodate to your body. Then when you remove that source of the adrenaline, this is where the patients become very depressed, because they've accommodated and this could be something that's been going on for 5-10 years. The patients who do have the disease, it's something that they have to continue to be scanned for and not let go. And it was the belief back several years ago that these were benign tumors. These are not benign tumors. And I can't tell you how many patients come to me with metastatic disease and will say, 10 years ago they said they just removed this tumor, it's benign, and I never have to be followed again. And that was unfortunate information that was given. So I tell every patient that comes and sees me, if you don't come back and see me again, you need to go and be followed for the rest of your life, at least annually, for this disease.